Okay, now I'm going to tell you about some eye injuries. Let's start with chemical injuries to the eye. Okay, as usual, alkali is worse than acid, right? Remember that acid causes a coagulative necrosis and alkali causes a liquefactive necrosis. And so the acids tend to cause an eschar that limits the penetration of the injury, whereas alkali can cause really deep tissue damage. The classic thing here is you want to irrigate the eye until the pH returns to normal. A normal pH is 7.4. Here you've got a corneal alkali burn that's less complete on the left, and then a really horrible looking corneal alkali burn on the right there.
So a hyphema, so this is bleeding in the anterior chamber. Most common, it's traumatic, but can be spontaneous, particularly in patients on anticoagulants. So complication here is you can get rebleeding, and it occurs most often when the clot retracts about 2 to 5 days later. You have an increased risk of glaucoma, you can get adhesions, you can get corneal blood staining, and can also affect vision. Here are some examples where you can see blood in the anterior chamber, and it's nice because you can actually see this even without slit lamp just by looking. So treatment, you are going to do bed rest. You can elevate the head of the bed. Some people do an eye shield, but emergent ophtho consult is necessary. So if patients have increased intraocular pressure, you want to treat it the same as you would glaucoma. So again, topical beta blocker, alpha agonist. You want to avoid aspirin, avoid anticoagulation if they can. And you know, if it's a low-grade bleed, if it's not too bad, they may be treated as an outpatient, but I think it would be prudent to get ophthalmology involved for sure. The picture that they're showing you an example of here, this is called an 8-ball hyphema, and these patients would typically get admitted.
So if you have a corneal laceration that's full thickness or you perforate the anterior chamber, that's an open globe. This can happen from blunt force trauma too. You get a teardrop-shaped pupil. You can see there's some uveal prolapse at the edge of that wound. That's a black pigment that's extravasating from the anterior chamber. And the classic finding here is Seidel's sign. So you fluorescein stay the eye, and then you can see it being washed away by leaking aqueous humor. Here's another picture of a prolapsed iris with a teardrop-shaped pupil. So don't put any pressure on this eye. That goes without saying. You want to place a hard metal shield. Don't perform tonometry. It's not useful. They need IV antibiotics. They need good analgesia. They're often sick to their stomach and need antiemetics. You should update their tetanus. The correct imaging here is a CT of the orbits and emergent ophthalmology consult.
So corneal abrasions. So this is when patients feel a foreign body sensation in their eyes. They can have some photophobia. They can get excessive tearing. You want to make sure to look for a retained foreign body. So this is an example of when you have to evert their lid. And if you're looking at the picture here, you can see the top picture. You can see these linear abrasions, and that's because every time you blink, you're basically abrading the cornea surface there. So the other thing that you want to make sure to do is you want to ask the patients if they wear contact lenses, right? Because contact lens wearers are at risk for ulcers, and you want to make sure that when you're treating these patients, you're telling them not to wear their contacts, and you treat them for Pseudomonas. So tobramycin drops would be indicated. So what else do we want to do for patients with corneal abrasions? You want to give them analgesia, right? You want to update their tetanus. Again, tell them do not wear contact lenses. Most of the time, they will heal within 3 to 5 days, but you certainly can refer them to ophthalmology. You can get recurrent pain there after resolution of symptoms, and this can happen with corneal erosion. So basically, you're just sloughing off the newly healed epithelium. And the thing that the picture's showing you here that you also want to make sure is to assess for herpetic keratitis. And this is very important, and you cannot miss this. In those situations, they're typically treated with oral medications like acyclovir.
Corneal foreign bodies. So this is so painful. It presents like a corneal abrasion. You need to do a good slit lamp exam here. If you find a superficial foreign body, you can take it out in the ED, but if you're concerned about a penetrating globe injury, then a CT of the orbits is the test of choice. The typical mechanism, and this is what I've done to myself, is you're welding or you're grinding metal and you're not wearing appropriate eye protection. If you get a metallic foreign body in your eye, then you can get a rust ring around it. So you want to get rid of that rust ring removal so you don't get permanent staining. Either do it in the ED within 24 hours or refer to ophtho.
So retrobulbar hemorrhage. So you can get this traumatic exophthalmos. You can increase intraocular pressure and can lead to acute glaucoma. Why do we care? Well, because this can decrease retinal artery perfusion and put you at risk for retinal ischemia. So you can get decreased vision in these patients. You get this proptosis. You can get a dilated non-reactive pupil. And you're going to treat this similar to glaucoma with medications to decrease the intraocular pressure, but they also need a lateral canthotomy.
Here's a couple of good reference pictures for how to repair things that you shouldn't repair. So lid margins, if you think the canalicular system is involved, if you've injured levator or canthal tendons, the orbital septum, if there's lots of tissue loss, these should be referred to ophtho for repair.